Hi there, my name's Dr. Brian Lipworth, and today I'm going to talk to you about simplifying strategies for using anti-inflammatory reliever therapy for your patients with asthma. These are some disclosures which you may want to look at. The first thing to say is the three key tenets of asthma, what I call the asthma triad, are reversible airflow obstruction, either spontaneously or as a result of treatment, like a beta agonist, type 2 airway inflammation, and airway hyperresponsiveness. The asthma outcomes pyramid are related to underlying type 2 inflammation. So at the top of the pyramid, we have symptoms and exacerbations, which you can elicit just by taking a history. Below that, we have airflow obstruction, which you can measure by spirometry or with a peak flow meter or using oscillometry, for example. Then we have the airway hyperresponsiveness, which is one of the tenets or hallmarks of asthma. And then we have the type 2 inflammation, which you can either measure by biopsy, sputum eosinophils, or by measuring blood eosinophils or exhaled breath nitric oxide. Now, the key to understanding the rationale for anti-inflammatory therapy, I think, is encapsulated in this particular slide, which shows that if there is a discordance or a disconnect between increasing use of SABA, albuterol or salbutamol, depending on which side of the pond you're on, and concomitant lower use of inhaled corticosteroids, in other words, over-reliance on the SABA and underuse of the inhaled corticosteroid, then that results in increased mortality. So what we've got to do, the trick here, is to make sure that the use of the reliever and the use of the inhaled steroid are always perfectly concordant, because that will mean that you can't overuse the SABA and underuse the inhaled corticosteroid, and that will lead to better outcomes in the long term. So there are two anti-inflammatory reliever therapies, depending on which side of the pond you're on. The one over here, and more globally, the anti-inflammatory is budesonide, and the reliever is formoterol, and that would be Symbicort, 106 over 4.5 to denote the relative doses of the steroid and the reliever. And the dose of that as anti-inflammatory reliever is 1 puff on demand as a reliever up to a maximum of 12 puffs in any given day. It has a licensed indication for 12 years and up. It's approved in the UK and globally for use on demand, or what's known as maintenance and reliever therapy, which is basically reliever therapy plus maintenance. It's not approved by the FDA for either use as anti-inflammatory reliever plus or minus maintenance, although it is recommended for maintenance and reliever therapy in the US guidelines for steps 3 and steps 4. So that's a little complicated. In the US only, there's another anti-inflammatory reliever inhaler, which is the combination of budesonide with albuterol, which goes by the name of Supra, and that has an FDA approved indication of 2 puffs on demand up to a maximum in any given day of 12 puffs, and that's for age 18 and above. It's not approved in the UK, and it's not approved anywhere else outside of the US at present, but that may change. One thing to say about Supra is it's FDA and guideline approved in the US only for on-demand use, but not as maintenance therapy, which again I will go into a bit more granularity. So this is a review article that I wrote, a rostrum article in the Journal of Allergy and Clinical Immunology in Practice recently in 2024, earlier in the year, just to try and illustrate and clarify in my own mind where these two anti-inflammatory relievers, either budesonide formoterol or budesonide albuterol, falls into place within the current GINA guidelines. So the simplest thing is to look at the bottom track, and that's using budesonide formoterol on demand, PRN, as anti-inflammatory reliever therapy at steps 1 and 2 for mild intermittent or mild persistent asthma, and then as you go up the escalator you use the same inhaler, budesonide formoterol, but this time as anti-inflammatory reliever plus maintenance therapy, and there the dose would be 2 to 12 puffs a day, normally 2 to 8 puffs a day, but you don't go below a maintenance dose of 2 puffs a day. The budesonide albuterol as anti-inflammatory reliever therapy, as I said, is only advocated by the FDA as reliever therapy. So strictly speaking, because it's not advocated as maintenance therapy, it should really only be used for mild asthma at step 1. But of course, it's very difficult to distinguish between mild intermittent and mild persistent asthma. So in real life, we're talking about using it on demand at steps 1 and 2. But it's definitely not indicated at steps 3, 4 and 5 on its own, but it is indicated as rescue therapy instead of albuterol, as additional rescue therapy instead of albuterol on top of regular ICS LABA or regular ICS LABA/LAMA inhalers. So I hope that's clarified where we are as far as that's concerned. At the moment in the US, budesonide formoterol is not indicated as either anti-inflammatory reliever therapy or as anti-inflammatory reliever plus maintenance therapy. And that's why we have budesonide albuterol over there. So if we move on to budesonide formoterol, used on demand as reliever in mild asthma, these are the main trials, Sigma 1, Sigma 2, practical and novel start, and this is from a review that I wrote back in 2020 in Annals of Allergy. And here we can see that in terms of exacerbations, using budesonide formoterol, the low-dose formulation, the 206, was superior to using SABA alone, whether that's terbutaline or albuterol in terms of reducing exacerbations, but was non-inferior compared to regular budesonide, low dose 200 micrograms twice daily. The other advantages you can see for using the budesonide formoterol is that over the piece, over the year, you'll end up with a much lower inhaled corticosteroid exposure compared to using budesonide regularly twice a daily. And bear in mind, in all of these studies, as you can see, looking at the adherence rates, because these were randomized controlled trials, were particularly high. In terms of the asthma control as the ACQ score, there were no differences or advantages of using budesonide formoterol compared to using albuterol or terbutaline alone. So we're seeing a reduction in exacerbations but not asthma control, and that's simply because these patients didn't have high ACQ scores to start with, so there was no signal to work on there. So I've tried to graph this. This is actually taken from a very nice review written by Richard Beasley from New Zealand in the European Respiratory Journal. And these are the trials comparing budesonide formoterol as an anti-inflammatory reliever therapy plus or minus maintenance compared to using SABA alone or compared to using inhaled corticosteroid with a separate SABA reliever. And these are the means and the confidence intervals. So a change where the bottom end of the confidence interval excludes 0 in terms of percentage exacerbation reduction is a significant reduction in the exacerbation burden. What you can see here is that if we start on the left, comparing budesonide formoterol as AIR compared to SABA, which are the squares, or compared to low-dose inhaled steroid with SABA as 2 separate inhalers, which are the triangles, that in 4 out of these 6 studies, that the budesonide formoterol was significantly better at reducing exacerbation burden. And then if we move to the right of the interrupted line, here we're looking at AIR plus maintenance versus low-dose inhaled steroid with SABA as two separate inhalers, which are the diamonds, and the circles are compared to using medium-dose ICS with SABA. And in this case, you can see that there is clear daylight between the bottom end of the confidence interval and the zero dotted line for exacerbations. So here we can see that using AIR plus maintenance is superior to either low-dose ICS or medium-dose ICS with separate SABA. If we move on to the next slide, here we have the trials comparing budesonide formoterol as anti-inflammatory reliever therapy with maintenance, so what used to be called MART, maintenance and reliever therapy, against ICS SABA fixed dose with a separate SABA inhaler. And here it's interesting to note from all of these studies, apart from one, that there was clear superiority in terms of percentage exacerbation reduction with the anti-inflammatory reliever therapy with maintenance, in other words MART, compared to the fixed dose ICS LABA versus SABA. So what I'm trying to say here is that it's actually much simpler to think of a continuum between mild asthma, genus steps 1 and 2, and moderate asthma, genus steps 3 and 4, using the one inhaler. So what will happen is that patients will use the budesonide formoterol, PRN, as anti-inflammatory reliever therapy at steps 1 and 2, and then depending on the prevailing trigger factors, if their asthma becomes more severe and it becomes more moderate at steps 3 and 4 for a period of time, then they will automatically escalate their doses to use effectively maintenance and reliever therapy. And then when the control's better, then they'll go back down the escalator, they'll de-escalate the dose to go back to using it just PRN alone. So you're going from AIR to AIR plus maintenance therapy, going backwards and forwards, up and down the escalator. So the simple mantra that I tell my patients is quite simple. It's this: it's use more when you need it and less when you don't. That's as complicated as it needs to be when using budesonide formoterol as anti-inflammatory reliever therapy. Use more when you need it and less when you don't, and then patients will automatically adjust the dose of their anti-inflammatory reliever therapy depending on prevailing trigger factors. So as you've probably gathered, I like to think as a continual spectrum of mild to moderate asthma rather than pigeonholing it into mild asthma and moderate asthma, because that makes sense depending on the prevailing triggers. A word here also is that beclomethasone formoterol has an approved indication for using maintenance and reliever therapy, but not as reliever therapy alone. So if you are going to use beclomethasone formoterol, then you're using it as an off-label indication. I think that's something that's worth mentioning it here. The only drug which you can use in this way, going up and down the escalator between anti-inflammatory reliever therapy plus or minus maintenance, is budesonide formoterol, at least if you're sticking to the labelled indication. So moving on to factors which you might want to consider when using guideline recommended preferred reliever with budesonide formoterol with the 206 low dose formulation, that this is recommended in UK and global guidelines but not recommended in US guidelines. It seems to me that it's a personalised, intuitive, flexible dosing regimen, so it puts the patient in control. And as I've already said, the mantra I tell patients to repeat back to me is use more when you need it and less when you don't. And it always ensures perfect concordance between the reliever, the formoterol, and the inhaled steroid, in this case budesonide, because if you take more reliever, you always get an additional dose of budesonide. That's the rationale. You can't overuse the reliever and underuse the inhaled steroid. So that's the beauty about this regimen when you've got them both in the same inhaler. It avoids the problem of overusing the SABA and underusing the inhaled steroids, which is what leads to problems. So, as you've seen from the previous slides, you get better control in terms of exacerbation reduction, but at the same time it's a win-win because the patient's exposed to lower doses of inhaled corticosteroid. It puts the patient in command of their own disease. And I think the last bullet point is it makes no sense to always commit patients to the same fixed dose of inhaled steroid irrespective of prevailing triggers. In the same way, you wouldn't give a diabetic patient a fixed dose of insulin and tell them to take that for the rest of their life, depending on their calorific intake or metabolic requirements. And to me, it makes no sense to commit a patient to a fixed dose of ICS because that will be determined by the prevailing trigger factors in terms of the type 2 inflammatory activity. Choosing the optimal reliever for your patient, well, the first thing to tell patients is that formoterol has the same rapid speed of onset as salbutamol, but a much more prolonged duration of action. So we're talking about 12 hours duration, whereas salbutamol is 2 to 4 hours. So you're actually giving them a better reliever, and that's worth telling the patient. Secondly, budesonide has been shown to upregulate and sensitize airway beta-2 receptors, and this results in an augmented formoterol reliever response in the setting of acute bronchoconstriction. And I've put the reference there in case you want to read that, which was from myself and Imran Aziz, published back in 1999, a seminal pivotal study showing that synergy between the steroid and the beta agonist. The other thing that if you are using the dry powder turbohaler for the budesonide and formoterol, then you only need a peak inspiratory flow rate of at least 30 litres per minute to deaggregate the powder and achieve optimal lung deposition, which is easily achievable when you're using the Symbicort turbohaler as rescue therapy in the setting of acute asthma. So patients can be reassured that they will get an adequate dose to the lung. The other point I'd like to make, and it's a question I'm often asked, is that repeated doses of budesonide will not result in clinically relevant systemic adverse effects. So if patients are using more budesonide because of the prevailing trigger factors, when they're using its anti-inflammatory reliever therapy, PRN, that won't give you significant systemic exposure. And that's because budesonide has a short elimination half-life of around 2 hours. So it's very rapidly eliminated from the systemic circulation. So this is an action plan which we would use. Again, keep it very simple when you're using the low-dose budesonide formoterol. And you've gathered by now the mantra for the patient is very, very simple. Use more when you need it and less when you don't. Up to 12 puffs a day, depending on symptoms and asthma control and prevailing triggers. But to seek medical advice if you're needing 8 or more puffs a day on a regular basis. And that's as complicated as it needs to get, in my humble opinion. So just to wrap up, budesonide formoterol is GINA approved as the preferred anti-inflammatory reliever therapy. Remember that you can use beclomethasone formoterol, but only as maintenance and reliever therapy. It doesn't have an approved indication for AIR per se. Patients can seamlessly escalate and de-escalate between AIR plus or minus maintenance therapy, and that's for the continuum of mild to moderate persistent asthma, depending on the prevailing triggers. It always ensures perfect concordance between the anti-inflammatory inhaled corticosteroid and the reliever, all wrapped up in one inhaler, so you don't have the inherent problems of using more SABA and less inhaled steroid, which is when you get the problems. Using AIR plus maintenance therapy, in other words MART, which is maintenance and reliever therapy, the same thing, I think is a suitable strategy and something I do for my patients with severe asthma taking biologics who are super responders or in clinical remission, because this will allow you to achieve inhaled corticosteroid sparing therapy. So they adjust the dose of their budesonide formoterol, or you could use beclomethasone formoterol in this instance as maintenance and reliever therapy, so that patients achieve the lowest possible inhaled dose of steroid. What I would say to you is that I wouldn't be using anti-inflammatory reliever therapy in this situation, because I think that patients with severe asthma should be left on at least a low dose of maintenance therapy with budesonide formoterol or beclomethasone formoterol. In other words, the lowest dose would be 2 puffs a day. So thank you very much for paying attention, and I hope you enjoyed this brief tutorial.